Thank you all for your attendance. صراحة it's an honor. Prof. آغا يعطيك العافية. It's a challenge and a privilege to present Dr. يعطيك العافية. رب. I just chose three cases. Central precocious puberty, as we know, it's sometimes straightforward, but it also can be a bit controversial. So I wanted to kind of make it more of like case based because we do have the knowledge or the education about it, but patients don't treat it as they say. Each patient is a bit different. So I wanted to present a few cases. In my practice, I mainly use the Ferelin, which is the Ferelin, the 11.25 and 32.5. I used to use Decapeptyl, but then now that it's not available anymore, it's not part of my practice. So most of the cases I'm going to be presenting are using these two preparations. Okay, so the first case is a 9-year-old girl. She's 9 years and 5 months. We presented to my clinic as a case of precocious puberty, already diagnosed. She presented at 7.5 years of age in an hospital with a development of Tanner 3 bilaterally, pre-market Tanner 2, and a growth spurt. Okay, investigations underwent investigation there. She did not do generic stimulation test, but she had a high basal LH FSH2, and as we've discussed, sometimes when your baseline is conclusive of central precocious, there's no need to go into generic stimulation test. With that, her bone age was advanced of about 11 years. So at that time, she started on picturelin, 11.25 milligrams every 3 months. And then she also started on vitamin D, a daily dose of 100 units with osteocare. When I examined her in my clinic, her according to the family, the breast development and the pubarchia were static. There's no further growth spurt. She was growing normally like she did before having any signs of puberty, and there was no vaginal discharge. On examination, her examination was normal. Her weight was from the 75th to 90th percentile, height on the 50th, and her midpointal height was 10 to 25. So you can say she was fairly tall for her family. And as you said, that is at the time of examination, not for this doesn't necessarily reflect her being a tall child later on or a tall adult. She was not dysmorphic. She had no hypo or hyperpigmentation, and she had a breast of Tanner 3 and pubarchy Tanner 2. So the reason I wrote soft is because sometimes your clinical examination is as crucial as lab work and other investigation. If the breast tanner is static and soft, it most likely means she is suppressed. So my conclusion of this was that she is suppressed on her dose of 11.25 of 25 every 3 months. So I wanted to give her a trial of, again, they had a problem of compliance and coming every 3 months. And since we had at that time 22.5 was released and had the same efficacy, so I wanted to give it a go. So I switched her to 22.5 IM every 6 months, made sure that she's taking vitamin D. At that time, when I did for her, vitamin D, it was low, so I kept her on a treatment dose with osteocare because she does not take any dairy. And I told her to continue on the vitamin D for 3 months. Even though I do this preparation every 6 months, I do not feel comfortable about starting a new medication and letting them go off for 6 months. 6 months, a lot can happen, especially with puberty. So I saw her in 3 months, and then I saw her again in 6 months. So this is the 6 month follow up. So her breast and pubarchia are still static. She has no adult odor, no vaginal discharge. Her height and weight are generally the same. Her Tanner staging was also the same. Again, with we know with pubarchia it doesn't progress. It can slightly progress, but it does not progress rapidly if it's the puberty suppressed. However, one of the most important markers for puberty suppression is that the breast development stays static. I did repeat her bone age. That at that point it was about maybe 2 years or 3 years after she started, then I did the same strategy. So then I think this confirmed for me that 2.5 every 6 months is just as effective. And at that time, she completed her treatment dose, so I was on vitamin D prophylactic dose of monthly with increased dairy intake. She's finally convinced. She's finally sick of osteocare, so I could convince her to take dairy every day. Okay. The other case I'm presenting, she presented to me at 7 year and 10 months, and she was already following up with a pediatric endocrinology clinic for center for puberty, and then she was diagnosed at 6 years and 10 months. At that time, she developed a Tanner stage breast health and two. Okay. So just to restart, so this is a 7 year and 10-month-old presented to the clinic as already diagnosed central precocious puberty. Central precocious puberty, and she was already diagnosed at 60 years and 10 months with breast development of Tanner 2. At that time, she did do a generation and she had an elevated LH. I didn't have the exact numbers because most patients don't carry their labs every time. And at that time, also she had an advanced bone age of about 1 year. She was started on triptorelin 11.25 IM every 3 months. When I examined her, according to the family, it was reported that her breast development was static. There was no pubarchy, and adult odor and vaginal discharge was on and off. The mom was not really sure. Uh, so on her examination, her weight was around the 75th centile, height was on the 50th, and her height was within her mid-frontal height, 50th to 75th centile. She was not dysmorphic, no hypo or hyperpigmentation, and her Tanner staging was 3. So that means it did progress since she was diagnosed and started on medication. And it's also firm. This is also important, even though there was no puberty. She did. So I have not gone it through a growth hormone, stimulation test. So instead, I did the luteinizing hormone 1 hour after giving her generation dose, and the result was 0.7. So that technically, according to our guidelines, is suppressed. However, when I repeated the bone age has advanced. So it was 8 years when she was diagnosed, and now it's 9.5 years, and it's still more advanced than her bone age now by almost a year and a half. The vitamin D was 23.9, and her alkaline phosphatase was on the higher side of 330. So I changed the frequency of the triptorelin to 11.25 every 2 months. I'm sure that's not in a lot of the guidelines, but in our practice, it's more common to kind of increase the frequency to cause more of a suppression, especially when clinically you can see that they're not suppressed. Even though I know the LH was clinically lab wise was suppressed, but we also go with our clinical impression. So what I did was I changed her triptorelin to 11.25 every 2 months. I gave her vitamin D treatment dose, and I increased her dairy intake because she insisted on not taking osteogear. Right after 6 months, so her the static, 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 adult odor, and everything discharge. Her her weight has increased to 75th to 90th centile. Her height now is from the 25th to 50th centile, and her mid-frontal height is 50th to 75. So this is something not a lot of places are reported, but I've noticed in the practice when you do effectively suppress with patients, you can have something what we call a catch down of growth, which they stop growing as fast as they were when they were not suppressed. So you need to monitor during that phase really well because some of them it can unmask the growth hormone deficiency or they can continue catching up later. The breast development at that point actually regressed and was very soft and there was no pubarchy. So for me, this is clinically suppressed central precocious puberty. I'm not going to repeat labs. I know. So I switched from having to take the injection every 2 months to 22.5 IM every 4 months. Okay. And I continued the vitamin D as a prophylactic dose. So I just wanted to point out that sometimes our clinical examination alone can be ineffective in confirming suppression of puberty without needing to do gonadotropin levels because sometimes gonadotropin levels can be full. And one of the most important things is clinically the patient is suppressed. There are times, especially when we have problems with private with insurance and with anxiety of family doing labs, sometimes it's more effective to just go clinically. And with it, the most important part is the follow-up. So even if you're getting an injection every 6 months or giving an injection every 3 months, following up every 3 months it will also put you at ease and put the family at ease that it's not very far follow up that they won't be able to see you and ask all the questions that they're not supposed to be. Okay. So this is a case that a brand new patient that I could present. She was 5 years and 6 months. She presented with breast development a month prior. There's adult odor with sweating. There's no pubarchy and no vaginal discharge. Systemic review, the only thing was that she had constipation. Otherwise, it's negative. Past medical history was negative. Family history, there's no consanguinity. There's no family history of precocious puberty or other endocrinopathy in the family. On examination, her weight and height were above the 90th percentile, while mid-parental height was 25th to 50th centile. She was not dysmorphic. There are no goiter. There's no hyperpigmentation. Her breast was on the left side was Tanner 2, and on the right side was Tanner 1. There was fine pubic hair. It could be considered as body hair. We do have those patients where you're not really sure this is pubic hair or just fine body hair. The red many in her examination was normal. She had one campheole spot on her abdomen with smooth edges measuring 2 centimeters by 10.3. Then the workup we have done, so the baseline LH was 0.12, her FSH was 0.58, estradiol was 24, so that's detectable. Her 17 hydroxyprogesterone was within normal, thyroid is normal, CBC, vitamin D, and A1C all within normal limits. And this was her born age. So to reiterate what Prof. Aga was saying, that sometimes radiologists do not look at the same things that we look at in the bone age. This bone age was reported as 5 year, 9 months, but when I reviewed it myself, this was easily 6.5, 7 years. So that is advanced for her age when she is only. So I'll pose questions to the audience. What's your most likely diagnosis? Would you depend on the radiology report or your own assessment? Is this straightforward? Obvious what the case is. If you want to start any medication, is there any medication you're thinking of? And do you want to wait and see? So I would like to start with the last question. Who would want to wait and see, and who would want to start? Who would want to wait and see? Hands, show of hands. And who would want to start medication? The examination? 5.5. So we know that LH or FSH are pulsatile. We've measured her labs in the morning. Yeah, exactly. So that's what I wanted to point out. Sometimes baseline alone is not effective, and you would need to do general stimulation. But if you do have estrogen, and you know that you have, uh, it's most likely a central cause. The chances of her being central precocious puberty are quite higher than it being an external secretion of or feminizing tumor, or we just isolated the peripheral precocious puberty and estrogen secretion. So sometimes when it's common, and you have to kind of follow your gut. So my impression was I used the clinical information that I've been provided by my examination. I do have a breast that is 10 or 2. That is abnormal in a 5.5-year-old. I do have a weight and height that is far above the mid-parental height. So the chance of it being a benign premature thyroid are quite low. The estradiol is detectable even if LH and FSH baseline are not elevated. The bone age is advanced. Using this information, I kind of strengthened my gut, and I diagnosed her as most likely she's central precocious puberty. I do think that maybe a stimulation test would have helped me confirm it, but at that time I thought this information would be enough and adequate, and I didn't want to waste any more time because this mom has been very anxious and has been seen by other people who told her she's okay. I do not think she is. I do think maybe it would be worth kind of maybe wait another 3 months, but seeing that the bone age is already advanced, I did not want to lose this uh, privilege of diagnosing her quite early. So I did start her on triptorelin every 6 months. I did give her vitamin D daily with increased dairy intake. I did follow her up. My plan was to follow her up every 3 months and do an LH after the GnRH dose for 6 months. And I was considering an MRI pituitary, considering her age is less than 6 years, and a pelvic ultrasound. But I was going to do that in the next 3 months. This is my last case, a case that I wanted to try at 22.5 from the beginning. The patient did come after 3 months of her, the first 3 month follow up, and she was doing okay. She's still 10 or 2 on one side, but it did not progress. Her increase in height was about was still about like significant, about 3 centimeters, but she didn't have any other signs of progression. So I'll let you know what happens in another 3 months. Any questions?
Thank you very much. Yeah. You, which is you. The question we have here, what was after I think the diagnosis and stuff that we do, HRH or PNRH test, make sure that they do not have suppress all mobile.
I try,
Have you started?
I don't do a growth hormone stimulation test. I do kind of an alternative one, which is I measure the luteinizing hormone level 1 hour after giving the injection. So usually like a stimulant, like the deferrelin that I just gave. So 1 hour after giving the deferrelin, we measure the LH stimulated. That indicates it's been stimulated. If it's still low, it's most likely suppressed.
Question if you are faced with it, you have already started.
Okay.
If you're going to use the 6 month period, the 3 month period, you are just your
True. So
no study,
yes,
no study about this. Say what most of the study in 6 months. Now you have a gap already.
started menses. So I kind of let the bone age also be my guide because if I do have an open bone age, I have time. It's not just her going through menses is enough of an indication that it's too late. So I do have one patient, but to tell you the truth, because she was 9.5. She already started her menses the month prior, and it was this for me is not center precocious puberty as much as rapidly progressive puberty because her first sign of puberty was when she was 8 years and a half. So within 1 year from starting her thelarchy, she developed her menses. So it's a very rapidly progressive puberty, not precocious. So she was a bit different. So I wanted to use the tools that I know are effective. So I did start 11.25 and immediately made it Q2. That's kind of my practice with those very progressive, difficult to control. I know she's going to be difficult to control, and her having one menses makes me want to be a bit more aggressive. So I did start her on 11.25. I started 2 months, and then within the 1 month after, she did have another menses, and then she stopped. After seeing her another 2 months for her next dose of 11.25, she was static, but still kind of like the breasts were still firm, the hair was still growing slowly. So I waited another 2 months, and then that time she was depressed, and then I switched her to 22.5 because she was also getting a little bit anxious with her injections every 2 months. So I told her I do have the privilege of doing it every 4, so I can do every 4, and I'm waiting for her next follow up. Absolutely.
But you know that it was no difference. I mean, even if it was 67, after 4 years open, the schools the two children. And when initially you need to reduce the interval between two doses, then it's separation.